Did this computer go? All right, the basic gist for this is yesterday I think you guys went over like the hypertension guidelines and application and all of that. I feel very strongly, as Brian has learned, about mechanisms of action, pharmacology, clinical pearls around the drugs versus the guidelines, and just getting you guys ready for boards, right? So you guys can see my screen, correct? All right. So what we're going to do is we're going to go through all the antihypertensives by class, and we're going to talk a little bit about some of the things that I think are important from a board standpoint. Is that fair? Does that sound like a decent use of your time? Okay. So let's pick a drug class to start with. Antihypertensive drug class. We'll start with you since you're to my left. What do you want to start with? Okay, ACE inhibitors.
I need to try and get on your screen.
You can't see my screen?
No. I was in like a Zoom meeting by myself. So.
Okay. Go to the schedule.
Yeah. With this? Or is there something I can...
That one.
Yeah.
Click on it.
That's what I did. I was just on Zoom.
Open launcher.
Yeah.
And then mute yourself if you would. Go ahead and join, but then mute.
Yeah. Thank you.
Someone's not muted. There you go. Okay, and turn your volume off. Can you see my screen now?
Yeah.
Okay, gang. Let's go. So what we're going to do is we're going to go through the ACE inhibitors as a class. We're going to try to name them all. You're allowed to cheat. Okay? We encourage cheating. Believe it or not. Okay? But we want to try to get them all out there. We want to try to talk about what we need to do when we start them. Hopefully some of this will be old hat. So give me an ACE inhibitor. We're going to just go around. This is called the ACE inhibitor game. Okay, what's the brand name?
Zestro.
What is it? Zestro. All right, are there any other brand names? Huh? Prenavil. Is that it? Okay, moving on. Next drug. Enalapril. I like it. Brand name? Hold on, I gotta take the safety strip off my keyboard. Enalapril. What was the brand name? Vasotec. Good. Okay, next one. Ooh, bring it in the old school. Brand name? Good. Capitan. Why don't we use that drug anymore? Probably because it's every 8-hour dosing, right? But it still is used sometimes. Captopril. Okay, go. What is it? Damn it. Brand name? You got it. Okay. Next. Hey, and if you give me a drug that's not made in the U.S., you flunk. So don't be looking at Wikipedia. Okay, you lose. Next.
Quinapril.
Quinapril.
Oh yeah.
Brand name?
APPE.
Good. Go.
Ramipril.
Okay, I like it. Brand name?
Altace.
Good. You got one yet? That's the only way I can really motivate you guys is through embarrassment and condemnation. All right, you're fired again. What is it? Okay, I like that. Is that made in the U.S.? Okay, it is. All right, go.
Benazepril.
Benazepril, an oldie but a goodie. I still see that sometimes. Brand name? Lotensin is correct. Are we running out or do we have any more? Okay. What is it? Moexapril? Yes, it is. Like that? Okay. Are we done? Don't worry about taking notes because I'm going to send this to you. Trendolapril. Is it made in the US? What's the brand name? What is it? You are correct. Okay. Are we done? We only got an hour, gang, so let's jump, jump, jump. Everyone say jump, jump, jump. All right. Are we done?
I think so.
Yes. Okay. What are the big side effects with these drugs we got to worry about? We're going to start this side this time. Go.
Angioedema.
Okay. Angioedema. Oops, Brian.
Cough.
Cough.
I got it.
Come on. Seriously? Nothing?
Just like elevation.
Okay, you're fired. Go.
Elevation and serum creatinine. I mean, I know it's only like have a modest elevation at the beginning, but
So renal hemodynamic. How do you want to call? What do you want to call this? What's happening? Can you explain it?
no.
How about we call it decreased glomerular pressure? Would you? Because that's what we're looking for sometimes. That's how we get renal protection. However, if you have an NSAID on board or renal artery stenosis, remember those nasty words? Then decreased glomerular pressure can result in acute renal failure, like pre-renal azotemia. Sound familiar? Okay. Does it? You're kind of, no? Yes? Pre-renal azotemia. Okay, let's stop then. I don't know if I can do this on here. Let me try. Is there a way to draw on a MacBook? Do you know? Let's see if I have anything where I can draw. Oh, here's a good picture. So, where'd it go? Okay, you got an arterial coming in, right? And you got a vein coming out of the nephron. Do you guys agree with that? All right. So, what are ACE inhibitors actually doing? What does an ACE inhibitor do?
If it's a angiotensin converting enzyme.
You get a gold star. Congratulations. I'm impressed, right? So angiotensin converting enzyme inhibits the conversion of angiotensin 1 to angiotensin 2. And what does angiotensin 2 do in the body? Like, what's it there for? Think about the physiology. Yeah, well, what is RAS? What's it there for? Making cupcakes? Does it help you poop? What's it do?
It's a vasoconstrictor.
It's a vasoconstrictor. It helps maintain vascular tone, right? So if we're inhibiting that, what are we doing to vascular tone? What's that? Vasodilating. We're vasodilating, okay? And so what winds up happening is you get selective vasodilation at the efferent going out renal arterial, right? Well, if we already have constriction going in, you can bottom out the blood pressure in the glomerulus. And that reduces filtration, it reduces pressure, it causes acute renal failure, right? Because we don't want the pressures too high, we don't want them too low. Does that make sense? Looking at this little picture? Okay. Now, anything else? How about contraindications? Is this okay doing it like this? Is this helpful? All right. Contraindications. When do you not give an ACE inhibitor?
The SCM's already high.
Okay, I'll take that. Hyperkalemia. What else? Pregnancy is a big one, right? And I know we talked about sometimes it's okay, like in certain trimesters, but let's, for your purposes, let a maternal fetal medicine physician do that. Because there's other safer, did I spell pregnancy right? No. Yes. Okay, when else? Okay, thank you. When else?
Renal artery stenosis.
Good. How about monitoring parameters? When do you want to monitor stuff? It's all, the answers are all here. So you're going to start me on an ACE inhibitor because my blood pressure is all high today. I'm stressed out, trying to teach you guys stuff. And you put me on lisinopril. What do you want to look at? Boots on the ground. Okay, so you're going to look at K. What else? Serum creatinine. Is that it?
Blood
You need-
pressure.
Yeah, good. But you know what? People will forget about that. Do you need to check me for pregnancy? Probably not. Okay. And then what else do you want to ask about? So review of system stuff. Cough, thank you. What else?
Dizziness.
Dizziness, good. Slash, let's call this orthostasis. Anything else we need to think about with ACE inhibitors? How about this? What are they used for?
Hypertension.
Okay, what else?
Renal protection.
Okay. In who?
Commonly diabetes and CKD.
Wait, isn't someone doing a talk on that today?
Yeah, me.
Sweet. Okay, what else?
Heart failure.
Okay, thank you. What else?
Like ACS, like MI.
Thank you, ACS. And does everybody know, is this ringing a bell? Okay. And what else? Secondary prevention of stroke, right? Aren't all post-stroke patients supposed to be on an ACE? Are we missing anything? We probably got them. So, the RAS system. Talk to me, folks. What is it? Where does it start? It starts with renin. I like where you're going. Can you go deeper? Wish I could draw on this somehow. This blows. Here, let's do this. I think, gang, as a APPE student in, how come this won't come up? Did I lose my internet or what? Good enough. All right. So there's your RAS system. Angiotensinogen is hanging around all the time, right? Your body, when it kicks in the RAS system, releases renin from the kidneys, which then in turn turns angiotensinogen, which is nothing. It's just crap floating around in the body. It has no physiologic purpose other than to be sitting there, ready to go in case the blood pressure drops. Angiotensin 1 does have some vasoconstriction properties, but nothing near angiotensin 2, right? So renin converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by ACE. Where is ACE made at? Do we know?
Probably the liver.
Some of it's in the liver. You guys won't believe this. A large portion of angiotensin converting enzyme is made in the lungs. Who would have ever thought that? Okay, and then angiotensin 2 then affects aldosterone, right? What is aldosterone? Is there another name for it? It's a hormone.
Antidiuretic.
It's an antidiuretic hormone, right? So what's the purpose of antidiuretic hormone? Okay, your body releases antidiuretic hormone to do what? To retain fluid for what? To keep your blood pressure up, okay? And how does antidiuretic hormone work? Huh? No, it is ADH. What's it doing? How does it keep fluid? How do we keep fluid? How do we get rid of fluid?
It activates the collecting ducts of the kidneys.
It does. To do what?
Opens up the little pores. I don't know what they're called. To allow water reabsorption to increase.
To allow water reabsorption via sodium retention. Do you guys agree with that? Okay. So when you keep what's it called?
Aquaporins.
Aquaporins. Okay. So it retains sodium. When we retain sodium, we get rid of what? Potassium. Okay. So that's what we're inhibiting, if you recall, with an ACE inhibitor, right? So the reason you have hyperkalemia is the aldosterone inhibiting effects downstream. This is all like review, hopefully. Brushing cobwebs off. All right. So think about it in your head. Angiotensinogen. Renin converts that to angiotensin 1. ACE converts that to angiotensin 2, which then stimulates aldosterone. And so if you think about all those things, then you can work through all of this stuff in your mind. For this drug, the ARBs, and for the renin inhibitor. Make sense? Okay. We good? All right. You get to pick the next drug class. All right. So angiotensin receptor blockers. Okay, go. Give me one. Brand name's Diovan. Okay, give me another one.
Candesartan.
Okay, I like it.
Brand name Atacam.
You wouldn't believe, I'll have to give you guys some dirt on how these drug names come about someday. I used to work for the pharma industry in their R&D. Okay, you did Candesartan, right? Losartan? Cozart?
I only know like 2 or 3 after that.
I wrote come back. Hold on.
Can I give her a hint? Look at the screen. I hinted you. Okay, brand name? I think that's it, isn't it?
Is it Vinicard? And there's Vinicard HCTZ. Okay.
Okay, next.
Irbesartan.
Okay, brand name?
Avipro.
How is it?
Avipro. Right? AVIPRO.
Okay, next.
Telmisartan. Novartis.
Okay. Is that it?
Found another one, but I hope it's in the US.
What is it?
Azilsartan.
It is.
Okay.
How do you spell it?
AZILSART.
A-Z-I-L.
And then SARTAN.
Brand name?
Darby. EDARBI.
Yeah, that's the US. Are we done?
That's all.
Is that it? Okay. So, what? Are we good? Speak up, or for now ever hold your peace. All right, can we do this? Can we just copy and paste?
For the most part.
All right, what are we missing?
Take out the column.
Okay, I like it. That it? Uh-oh, I better not open that text message in front of you guys. Never know what it could be. It could be the test results. All right. How do we feel about these? When do we use ARPs?
An ACE is contraindicated.
When an ACE is contraindicated, usually for cough. Okay. Next drug class. I think it's your turn, bro.
Thiazides. Or thiazide one.
Why don't we just call it diuretics? Is that fair? Okay. So what are our diuretic classes? You picked it, so you have to do diuretics. So you said thiazides.
Thiazides.
Okay.
Carbonic anhydrous.
Yeah. You're the first student in years that's actually pulled that out. No one ever remembers the carbonic anhydrase drugs. Okay. What else?
Aldosterone antagonists.
Okay. What else? This is your chance to redeem yourself. What are kind of like the aldosterone antagonists, but not actually aldosterone antagonists? You want to phone a friend?
Yeah, right.
Potassium sparing diuretics.
Okay. So these are your diuretics. Everybody agree? Okay. What do we usually see used in hypertension? Okay. Thiazides. Go. Give me one. Okay. Next.
Chlorthalidone.
Next. Should I never spell this right? I mean, shoot. Okay. Oh, wait. We're forgetting brand names. People. HCTZ. I think it's also called diuryl, isn't it?
Yeah. Or hydrodiuryl.
Yeah, hydro. Okay, chlorthalidone.
Palitone.
What is it?
Palitone.
Huh?
That's what it says. Maybe that's a brand and not the U.S.
No, just what is it? I can't hear you.
Palitone.
Like this?
What's the company? Is diuryl for chlor.
Like that? All right. How about metolazone? Zeroxylin. Yes. Zeroxylin. I think, did I spell that right?
There's another O. Yeah, after the X is OXO.
Like that? Okay. Next drug?
Indapamide.
Okay. Brand name?
Lozol. L-O-Z-O-L.
Okay. Next.
Just plain chlorothiazide.
Okay. Brand name?
Sportside that says diuryl.
Yeah,
Did
I thought you said chlorothiazide. I read it wrong. You said chlorothiazide. No.
Can't work under these conditions. What's the brand name for chlorthalidone then?
Is it just Palitone?
I don't know.
I'll look it up.
Okay.
That's what I see. Palitone.
Side effects, gang. What do we got? Let's start over here, lefty. Side effects of thiazides.
I mean, I think hypokalemia.
That's probably the biggest one, wouldn't you agree? Okay. Anything else big?
I'm looking, because I would have said hypokalemia.
The other electrolyte,
Hyponatremia.
Photosensitivity.
Hmm?
Photosensitivity.
Photosensitivity. What else? Yep. We commonly overlook that, but it is a big problem.
Hypercalcemia.
I like it.
Talking about that.
Okay. I think that's probably good, don't you guys? For side effects. Maybe orthostasis, but not really. Diuresis, you got to pee all the time. That can be a side effect if you're stuck on a bridge, right? Okay, monitoring.
Electrolytes.
Be more specific.
Well, it's like if you're looking at calcium or hypercalcemia.
Okay. Does that come in a lab or?
Yeah.
What?
Or like a BMP. Or a
Is calcium in a BMP?
A CMP.
Okay. So we're going to say calcium, potassium, anything else?
Sodium.
Okay, that it?
Blood pressure again.
Probably. That should probably be in there for all of them, right?
we need to monitor renal function.
Why? Talk to me. How common is it that you're going to over diurese somebody with a thiazide?
I think I mostly see the worry with like IV lasers.
You can actually over diurese somebody with indapamide and metolazone because those are such potent diuretics compared to like chlorthalidone. So we'll put serum creatinine in here. Why else would we want to monitor serum creatinine or renal function in these drugs besides that we're causing problems?
I know they have like renal dosing.
So renal dosing, when do they quit working for hypertension? Does that sound familiar? Yeah? Okay. So let's talk about the actual thiazides. What do you see used the most? HCTZ. Why? Why? It's cheap. What's the half-life of HCTZ? Someone look it up.
Six to 15 hours.
What is it?
6 to 15 hours.
Is that 24 hours? Do we dose it twice a day?
No, because you don't want them to have to feel it.
No.
You can, but I mean,
Okay. So you actually can have some lapse in antihypertensive control with this drug. What's the half-life of chlorthalidone?
40 hours for a single dose.
40 hours for a single dose?
45 to 60.
Which drug is actually used in the big clinical trials that said thiazides work well? So I'm going to put EBM next to it. Does that make, do you guys know what that means? Evidence-based medicine? Okay. All right. Are we good? Is this helpful or is this way below? Am I like insulting you all's intelligence?
Sure.
Okay.
blood pressure.
Okay, let's go to loops. Talk to me about some loopies. Let's start over here.
Furosemide.
Furosemide, brand name,
It's
Lasix. Why do they call it Lasix?
the last 6 hours.
Okay, give me another one, Brian.
Torsemide.
Brand name?
Avidex.
Is it? I just made that up. Is it really it?
Yeah.
Yeah.
Okay, just checking.
I think I'm just gonna make one up.
Yeah. Half-life on torsemide. Or duration of diuresis. Hey, we're halfway through. We got to roll, guys.
3 to 4 hours. 6 to 8 for diuresis.
For torsemide? Thought it was longer than that. Okay, next.
You guys. Half-life is the 1 to 1.5 hours.
Okay, next.
Hyperchronic acid.
Huh?
On there.
It's listed in there, yeah. I've never heard of it. But
Either.
brand name Edicrin, EDECRIN.
It's already there. Why do we use it? Why in the world do we use ethacrynic acid? It's for use in somebody who has a true sulfa allergy to a loop diuretic. Okay? All right. Carbonic anhydrase inhibitors. This should be easy. I think there's only one.
Seems old.
Uh-huh. Okay. When do we use those drugs? Oh, wait, let's go back to loops. We forgot some crap. Okay, let's cut and paste. You guys even looking at my screen?
Yeah.
All right, side effects. Hypokalemia, yes or no?
Yes.
Hyponatremia, yes or no?
Yes.
Photosensitivity, yes or no? Can. Erectile dysfunction, yes or no? Huh?
No.
No?
It's just, I have no idea.
I don't know. Look it up. Hypercalcemia, yes or no?
No.
It's hypo. In fact, we'll sometimes use IV Lasix or furosemide in patient to try to drop calcium levels in hypercalcemic patients. Do you guys know you have to correct calcium levels? Everybody know that?
Yeah.
You two aren't nodding your head.
Yeah.
Do you know that?
Yeah.
Okay, do you?
Yeah, I had to do it.
Okay. Do you know how to do it? Do you know the secret trick?
I'm not doing a secret trick. I pull up the calculator.
Yeah, you don't even need that. What's a normal albumin?
4.
4. Okay. So every point below 4, your albumin is, you increase the calcium by 0.8. Okay? 1 to 0.8. So if it's 3, then you've got to correct your calcium up by 0.8. All right. Diuresis. Do we expect diuresis with these drugs? Yes. We want to monitor calcium, potassium. What's one we're missing in here that's important for loop diuretics? Thank you, Mag. Serum creatinine is probably even more important because we get worried about pre-renal. And when are these drugs used for hypertension? When the thiazides are no longer useful, right? Used for hypertension in creatinine clearances less than or equal to 30 mils per minute. All right, we good? Move on? Let's keep going. Okay, carbonic anhydrase inhibitors. Very rarely will we use these for blood pressure anymore, but I think it's important we talk about them. When do we use them? pseudotumor cerebri, which is also called idiopathic, not indio, idiopathic intracranial hypertension. And what's the other one?
We do have glaucoma.
Okay, glaucoma.
Yeah.
Yeah, and there's actually a third one then. I forgot about glaucoma. Elevation sickness. Everybody who climbs Mount Everest gets a little acetazolamide in their pack. How do carbonic anhydrase inhibitors work? It's in the name.
It inhibits carbonic anhydrase, which is
What's carbonic anhydrase do?
converts bicarb to CO2.
So you're basically inhibiting the production of CO2. Yes, no, maybe?
So,
Guys are killing me, Smalls. You're killing me, Smalls. That look familiar? So if you go climb a mountain, what happens to the oxygen level? It drops. So if your oxygen level drops, what happens to the oxygen level in your body?
also drops.
That also drops. What do you start doing when you become hypoxic? What happens to your respiratory rate? You hyperventilate, respiratory rate goes up, right? So if you start doing that, you're not getting more oxygen, but what are you doing as you increase your respiratory rate? You blow off CO2, right? So you're blowing off CO2. What is CO2 in the body? What is CO2? What is carbonic acid in the body? It's an acid, right?
That's what you're looking for.
Yeah.
No.
It's that easy. So elevation sickness is basically a respiratory alkalosis. Do you guys agree with that? So if we give a carbonic anhydrase inhibitor, we're actually keeping more CO2 in the body. Do you guys agree? So we're compensating with a metabolic acidosis. Does that make sense? So anytime you give a carbonic anhydrase inhibitor, you're worried about creating a metabolic acidosis. Does that help? Okay, because you're inhibiting this. So you're inhibiting the transformation of CO2 to bicarb. So you're keeping more CO2. So you had it right. I just want to make sure you guys are feeling me. All right. Aldosterone antagonists. Help me out. Spironolactone. Brand name? Oh, we forgot the brand name for acetazolamide. Thank you. Okay, spironolactone. What else? Aplenerone. Did I spell it right? I don't think I did.
R instead of that N.
Where?
Right there. So ER. EN.
Aplerenone?
Yeah.
Really?
Yeah.
Okay, brand name? Thank you. That it? Indications, when do we use them? Hypertension. What else? Heart failure. Thank you. When else? Thank you. Monitoring. Okay, blood pressure, right? All that crap. Do we need to go any deeper than that? What do these drugs do in dudes? Thank you. All right. Now, do both of them?
Not as much in Epler.
Is that really how you spell it? God, that looks weird. Okay. Okay, what are our potassium sparing drugs? Okay. Amiloride. Help me.
ORID.
AMIL.
ORID.
Okay, what's the brand name of triamterene? Do we ever just give triamterene? It's usually HCTZ triamterene, right? Diazide or Maxide. Do you guys still see that used? Okay, what else? Amiloride, brand name? What is it? MID what?
AMOR.
I haven't heard that in so long. All right. Why are these drugs different? Why don't we just call them all potassium-sparing diuretics? Where do these drugs work?
They work like on the tubules.
These drugs, potassium-sparing diuretics, work at the very far end of the distal convoluted tubule. You agree? Where do the aldosterone antagonists work? You had it.
The collecting duct.
Yep, collecting duct. They work. They have two completely different mechanisms of action. So we can't really classify them all together. Some people will, but I think so that you guys know that there's a different mechanism of action, it's important that we differentiate. Hey, we're done with the diuretics. You guys did pretty good. Proud of you. Okay. Whose turn is it to pick the drug class? Cheers, down there. Yep. Okay, types. Okay, you picked him, you get to start. What's the first dihydropyridine you want to pull up? Brand name? Thank you. Next. Brand name? You know you're old when you remember when these drugs came out and they were like, this is the next best thing. Brian?
The carbidine.
Huh?
Cardine.
Thank you. Brand name?
Cardine.
Thank you. Next.
Nifedipine.
Brand name?
Elat. Nifediac.
Nah, no one ever uses that. Procardia is probably the other big one that you'll see used. All right. Next.
Nisoldipine.
Okay. Brand name? Yep. Okay. Next. Oh my God.
There's a lot, but I haven't
One
heard of them.
gazillion of them.
I know, and I haven't heard of them, so I don't know if they're.
We got to hurry. I only got like 5 minutes. Nimodipine.
Nimodipine, yeah.
Okay. Brand name? Huh?
NYMALI.
Nobody uses that. Thank you. Nematop. Let me tell you, this drug that you're looking at, huh?
I hate those at work. We have to like pull them with a syringe out of a capsule.
Yes.
Oral.
Yes. Do you know why?
I know that people have died when they used it intravenously. They're supposed to use it oral.
Okay. Nimodipine is predominantly used not for hypertension because it's ungodly expensive. The reason we use this drug is it probably has the highest lipophilicity of any of the dihydropyridine calcium channel blockers. And the primary indication for it is to prevent post-stroke vasospasm. Do you guys remember that from your stroke lecture? So you get worried about delayed vasospasm-induced ischemia, especially in subarachnoid hemorrhage. So that's when we use that drug. That's predominantly the only reason we still use it. Okay? Are there any others? Just, huh?
I don't know how to pronounce it, but it's spelled Nilvadipine.
Novatapine?
Yeah.
Brand name?
With Alvil.
Spell it.
Nibaldil.
DIM? Is this still in, is this US available?
There's another one. Clopidogrel.
That's one I know of. How do you spell it?
Clevivipine.
Brand name?
Levoprex. Clevipirx.
IPIRX?
REX. Levoprex.
Okay. All right. What do we got to worry about with these drugs? Big ones. Obviously, blood pressure. What's the other one?
Flushing.
Hmm?
Flushing.
Is that a big one with these?
Edema.
Edema is for sure. Okay. Blood pressure, edema, constipation, but not really bad. Okay. What else? That it? Do we have to monitor anything on these drugs? Blood pressure and edema. You agree? Okay. What? Oh, you're yawning. I thought you had a question. That's how some people ask questions. Okay, non-dihydropyridines. Someone help. Verapamil. What's the other one? Oh, we forgot something up here. Side effects of dihydropyridines. Blood pressure, edema, constipation, reflex. Thank you. Reflex tachycardia. So the heart rate actually goes up a little bit with dihydropyridines. Is that what you people are trying to tell me? Nod. Okay, non-dihydropyridines, verapamil, DILT. What's the brand name of verapamil? Verilan, Kalin, right? Sound familiar? How about DILT? Cardizem.
Yeah.
Tiazac? No?
Yeah.
Yeah.
Oh.
I've never seen the other one. I've just seen Tiazac and Cardizem.
Extended release, you have like ST and XT.
Okay, yeah, whatever.
I've seen that.
Huh?
Well, for the extended release of cardia.
Cardia?
Yeah.
Okay. Okay. What's the side effects with these drugs? Blood pressure? Edema? Nah. Constipation? Next. Huh?
Bradycardia.
Thank you. Bradycardia is a big one. And what's even worse than bradycardia? What happens when you get too bradycardiaed? Thank you. Okay. When do we use these drugs? Really ever? AFib? Anything else? Resistant hypertension? That's about it. Verapamil, migraine prevention. All right. Next drug class. It's your turn. Thank you. Metoprolol. Brand name. Okay. Next. Brian,
Atenolol.
brand name.
Tenormin.
Tenormin. Tenormin.
Norman.
Thank you. It's been a while. God, why does my mouse keep mousing around? Go.
Isoprolol.
Bisoprolol.
Zabeta.
Okay. Go. Propranolol. Brand name. Next. Nadolol. Brand name? What is it?
Core guard.
Okay, next.
Sodalol.
Let's not put Sodalol in there because even though it is a beta blocker, it's really an antiarrhythmic versus an antihypertension drug. Technically, you're correct. Give me another one.
Would you consider Sodalol?
Oh, yeah.
Stop.
Did I spell it right?
Yeah.
Okay, next.
Acetylol. Sacral.
What is it?
Sacral. S-E-C-T-R-A-L.
Okay, next. How about Betaxolol? Brand name? I guess let's not do brand name on that because there's oral and ophthalmic. So that can throw people off. Give me another one. Brian, hurry up. Come on, dude. Oh my God. How about Esmolol? What's the brand name of Esmolol?
Reviblock.
What is it?
Reviblock.
Thank you. Reviblock with a C.
With a C.
Any others?
Reviblock.
Okay, thank you. Brand name?
Core.
Thank you. Next. Thank you. Labetalol. And brand name?
Transdate.
Thank you. Are we good? Okay, what are your beta selectives? Beta 1 selective.
Metoprolol.
Metoprolol, bisoprolol, atenolol, esmolol. Thank you. Next. Okay. Nope.
No. Oh.
Thank you. Nebivolol. That it? Nope, not yet. Thank you. Okay, those are your beta 1 selectives. Come up with a mnemonic you like. Here's mine. Beamin. I really like, so I'm beaming on my baby beta blockers. I don't know. It's stupid, but whatever. Okay, side effects. Go. Bradycardia is a big one. What else? Orthostasis. Next. Fatigue. Thank you. Next. Hurry up. Depression. Did you say ED? It is. Nope. Anything else? Okay, AV block.
Not really kind of side effect, hide the effects of hypoglycemia.
Yes. Hypoglycemic unawareness. Right? All but what? What symptom?
Sweating, I think.
Sweating. That's the only cholinergic one that it doesn't do. So let's run through these drugs. Metoprolol, atenolol, bisoprolol, propranolol. What do we need to know about that? It's the most lipophilic. That's why you see it used for a lot of the CNS indications like tremor, like anxiety, like migraine prevention. Nebivolol, how is that drug different? So it's a direct vasodilator in addition to its beta blocking effects, right? Esmolol. It's parenteral. That's what you see used in-house sometimes. Carvedilol, what's the deal with that? Labetalol. Okay, we get the beta blockers pretty good. Hey, who needs, are you going downstairs to do your thing?
Yeah.
Okay, go. You better go down and get set up. Indications for beta blockers.
Thyroid storm.
I like it. Okay. It's a way to pull it out of the butt. Heart failure, good.
Am I?
Okay, that it?
Hypertension. Well, that was that.
Yeah, sure it is. Resistant hypertension. That it? Thank you. Angina. All right. What are we missing drug class-wise? Alpha-1 antagonists, right? Prazosin, doxazosin. I don't even remember how to spell it. Doxazosin. Tamsulosin and terazosin, right? Side effects, orthostatic, hypotension. Those are the big ones. Do you agree? Okay. Indications. Resistant BP, BPH, and I'm getting ready to dump some crazy stuff on you here. PTSD? What? Yes. You guys heard that before? Okay. All right. Alpha 2 centrally acting agonists. Clonidine, thank you. Spell it right, Herndon. What else? About guanfacine. Okay. Side effects. Thank you.
Consider methyldopa.
Yes, thank you. When do we primarily use methyldopa? Prego. Is that a bad term? Like, does that offend anybody? Okay, I don't know. I'm so out of touch. Rebound hypertension. Is that it? For side effects? Hypotension is a big one. Headache. Thank you. Indications. Hypertension. How about ADHD? Any others?
Quantity we use for tremors.
Thank you. Tremor. And let's say opioid withdrawal. All right. Thank you. Drugs. Next. Thank you. Next.
Minoxidil.
It doesn't work for baldness, just saying. Okay. What are the side effects with these drugs? Headache's a big one. Huh? What else? Who said flushing earlier? That's a big one.
Is it rash?
Lupus, like rash, with hydralazine, primarily. Hydralazine.
Worse than after.
Yes. Okay. We good? When do we use these drugs? Baldness. Heart failure. When else? Angina. Okay. Resistant hypertension. Was this helpful? So did we miss any big blood pressure drugs? We talked about every blood pressure drug. Huh?
Entresto, the new class.
Wait, that's not a blood pressure drug.
Oh, for heart failure.
That's a heart failure drug. What is it?
It's valsartan.
So we know what valsartan is. What's the other part?
Sacubitril.
And what does that do?
Neprilysin inhibitor.
It's a neprilysin inhibitor, which does what?
Affects bradykinin.
Good. Okay, I will send this to you guys. Stop. How do I do this? No.